We are meeting for our urology lecture, and we'll be discussing about urinary stones, what we call calculi, or what we also call urolithiasis. And by the end of today's lecture, I'll be happy if you guys can appreciate the etiology, understand the pathophysiology of these urinary stones, how to investigate for these stones, and then how you manage, and the different modalities and how you select them. So, in the epidemiology of urinary stone diseases or disease is the third most common urological problem after UTIs and problems related to the prostate. It affects approximately in industrialized countries, and the lifetime risk for stone formation approaches 20% in the adult Caucasian men and about 5 to 10% for the women. Adult men are affected 3 times as often as women, and the stone disease in adult Caucasian men is about 25 to 30% more common than in black men. So in the risk factors of this this problem include dehydration, those people who take little fluids, and this is of course because, as we shall see in the pathophysiology later, you need concentrated urine, which can arise from stasis and dehydration. And so in populations where fluid intake is less, you have more stones. And then we already said the disease seems to be more in the females than in the males, although you meet literature where they are almost the same. Geographical location, people who are in locations where it is hot will tend to experience urinary stones more. Even in areas where people have different seasons, like like in these countries where you have winter, summer, spring. So in summer, during summer, the sun is a lot, and it is believed that they will also get more stones during the summer. If you have history of stones, if it tells you they have ever had stones, then you should always suspect them to have stones. And as we shall see later, when you remove a stone from someone, they have 50% chances of these stones recurring. Family history is very important, because some lesions that lead to stone formation are actually familial. Obesity, and we also have metabolic disorders, hyperparathyroidism and the like. Infections are also one of the predisposing factors. We shall look at the stravite stones, and we shall see how these get infected, promote the stone formation. We also have infections in the GIT, and these may also predispose, like the bowel inflammatory disease. We also have diet. We shall see how it relates, and of course some drugs. You'll meet something called the protease inhibitor stones, and these are predisposed to stone formation. So when you have a patient you suspect to have stones in the urinary tract, you can do investigations including the imaging, blood investigations, and urine. And in the imaging, usually you want to start with an abdominal ultrasound scan. It will be able to pick these stones. Of course, the ultrasound scan can miss some stones, but usually it is very important, especially if the stone is causing obstruction. If it is the upper urinary tract, you will see hydronephrosis, hydroureter. If the stone is in the bladder or the kidney or the ureter, you still see it on ultrasound scan. And then we have plain abdominal x-rays. As we shall see, the calcium stones are radio opaque, but there are some stones that are radiolucent, especially the uric stones. So doing a plain abdominal x-ray and you don't see stones does not mean they are not there. The abdominal CT is also more sensitive compared to a plain abdominal x-ray. And you can combine the CT with contrasts, what we call the CT urogram. It can show you the whole of the urinary tract. The IVP is also a substitute of a CT urogram. The IVP uses the usual x-rays, but these patients are given contrast. In the blood investigations, especially for urea and creatinine, especially if you have, if a patient has only one kidney and is obstructed, or when they have bilateral kidney stones, you may want to see how the calcium is, uric acid, and the full blood count may also show you in case the patient has already has renal failure. You do a urinalysis. pH is one of those important aspects in urinary stone formation, but also you may want to look out for signs of infection, white cell count, and pyuria. So in the pathophysiology, there are several theories of stone formation, and stone formation requires conditions like supercirculation of ions. You know, when we say supercirculation, it means that you've added a solute into a solvent until that time comes when any more addition of the solute leads to no dissolution. So hypercirculation of ions. Nucleation is the real beginning of the stone formation. You may need urine stasis, like we had said, or low urine volume. Like we said, dehydration predisposes stone formation. So supercirculation of ions depends on the urinary pH, the ionic strength, the solute concentration, and complexion. Complexion simply means that there are some ions that actually bind to others, and so we say they have complexed. And so when one ion is away, then the other one does not have anything to complex with, and therefore you will have that particular ion more for absorption, and therefore it is likely to be more concentrated in the urine. Then complexion, yes, that's what we've just talked about. And an example is calcium complexes with oxalate and decreases the free ion, the free ionic form of oxalate. So in other words, in the bowel, if there is no oxalate, then calcium will be more, because there will be more calcium. Therefore, you will have those stones forming. The other example is the sulfates. They also complex with calcium, and so if they are not there, calcium will be free for absorption in the GIT, and the more calcium you absorb in the GIT, the more calcium you have in blood, and therefore the more calcium that is likely to be in urine. Now, on nucleation, the nucleation theory suggests that urinary stones originate from a proteinous matrix, crystals, or foreign bodies like a catheter. And when these are immersed in a supersaturated urine, then you may have stones forming. So there are two concepts. One of them is the heterogeneous nucleation, and the other is the homogeneous nucleation. And what they simply mean is that if you say, for example, you have a calcium stone, the nucleus is calcium also. But you can also have sodium being the beginning and then calcium builds on. So when that happens, then you talk of the heterogeneous. If the nucleus is calcium and the stone is calcium, then it is homogeneous. Now, the other thing you need to know is that they are crystal inhibitors. And for this theory, the crystal inhibitor theory claims that calculi form owing to low concentration or absence of the natural stone inhibitors such as citrate, magnesium, sulfates, and pyrophosphate. So these are stone inhibitors. We have, ideally we would all be forming stones, but because we have these in our urine, they inhibit the stone formation. And we also have those that we think are urine stone forming promoters, and they include the monosodium urates, which absorb and adsorb urinary stone inhibitors, and therefore facilitating and E. coli does not fall in this, and as you know, it is the commonest cause of infections. So if you do a urinalysis or urine culture and sensitivity and you find that it is E. coli, then infection stones are very unlikely. They are 3 times more common in women than men, and they may recur rapidly. And they frequently present as renal staghorn calculus, which require removal to control the infection. So if someone keeps treating infections without eliminating this staghorn calculi, then you have recurrent infections. So when you see someone who has infections and they are not being controlled, you should also suspect that they may have these stones. Now, the bacterial enzyme urease causes degradation of urea to form ammonia. The ammonia undergoes hydrolysis to form ammonium and hydroxy ions. The resulting urine alkalinity enhances the dissolution of phosphate to form triphosphate ions, which reduce the solubility of stravite. So stravite stone dissolution, therefore, requires that you acidify the urine, and this may be achieved by the subwise G solution, or what we also call renacidin. Now, the uric stones, these ones occur in people who have gout. These stones are usually found in men. They are associated with urine pH of less than 5.5. They are associated with high purine intake, like the meat, the legumes, fish, meat extracts, and gravies. Of course, gout, we already said, malignancies, rapid weight loss, and dehydration. However, most patients with the uric acid stones actually don't show a lot of uric acid in their serum. If serum or urinary uric acid is elevated, then the patient should be treated with allopurinol at a dose of 300 milligrams daily. Now, the cystine stones are secondary to cystinuria, and these are inborn errors. You remember we talked about those congenital problems. If patients have family history, they may actually have these inborn errors. And they are relatively radiodense because they contain sulfur. They are very hard and relatively resistant to some of the modalities of treatment we shall see, like lithotripsy, and they have a high recurrence rate. The therapy includes high fluid intake and is alkaline, and so you keep the pH more than 7.5. Cystine stones can be dissolved with a variety of thiols, including the D-penicillamine, the N-acetylcysteine, and the alpha-mercaptopropanyl glycine. And all these can be very good in treating cystine stones. Now we also have the xanthine stones. They are very rare. They are secondary to also a congenital deficiency of the enzyme xanthine oxidase, which catalyzes the oxidation of hypoxanthine to xanthine and xanthine to uric acid. And deficiency in this enzyme results in increased levels of hypoxanthine and xanthine in blood and urine, and of course lowers the levels of uric acid. Now, oral medications for stone treatment include the alkalinization of the urine. You have gastrointestinal absorption inhibitors. You also have phosphate supplements, diuretics like thiazide we've already talked about, calcium supplementation, uric acid. In those ones you can use allopurinol. And then of course we have urease inhibitors for the infection stones. Now for alkalinization, we have sodium or potassium bicarbonate, and we also have potassium citrate. Of course, the citrate is metabolized to bicarbonate and therefore achieving what you want. Polycitrate contains potassium and sodium citrate, and also citric acid. And this we know you can get from oranges and lemon. And then Bicitra contains sodium citrate and citric acid. Orange juice, as I've already said, alkalinizes urine, and so you can use it. And of course, there are also IV alkalinization, which is effective with 1 to 6 molar sodium lactate. Then tromethamine E, and tromethamine can produce also pH of 8 to 10, and are especially effective with the uric stones. We say the uric stone formation requires acidic urine, and therefore these agents can actually be effective. Of course, also for the cystine stones. Then the surgical management, we have modalities that include lithotripsy. Lithotripsy means stone fragmentation. We shall see how we achieve it. We have lithotomy. This one is the physical removal or extraction of stones. If they're in the blood, open the bladder, pick the stones and close the bladder. And we also have lithotripsy, and this means you mechanically crush the stones. There is equipment, for example, you can pass transurethral into the bladder and crush the stones. And of course, the small fragments are able to come out by themselves. The approaches can be extracorporeal, in other words, outside the body. They can be endoscopic, and these ones are called minimally invasive, or you can have percutaneous methods, which are also considered to be minimally invasive. But of course, in our setting, the commonest you will see is open surgery, which is invasive. Open surgery means if there is a stone in the bladder, you open the bladder and remove it. If it's in the ureter, you open the ureter and remove it. So in the upper urinary tract, we have nephrolithotomy, and we can have the percutaneous one or the open. Nephrolithotomy therefore means that if there is a stone in the pelvis or in the kidney, you just operate open, do open surgery, and then you remove the stone physically. You also have pyrolithotomy. If you have a stone in the pelvis, you can use the percutaneous route, or you can do open surgery. We also have ureterolithotomy, and in this one, you want to remove the stone from the ureter, so you can either do endoscopic ureterolithotomy, or you can do the open method. And for endoscopic, you go through the bladder, go through the urethra, enter the bladder, enter the ureteric orifices, go up the ureter and pick the stone. Then in the lower urinary tract, we have sistolithotomy. Cysto is for the bladder, so you can do it either endoscopically using a grasper. You can do the open surgery, or you can crush the stone with a stone crusher in the bladder. And then you have also urethrolythotomy. This one is when the stone is in the urethra, and you can either do endoscopic or you can do open procedure and pick the stone out. If the stone is in the navicular fossa or the fossa navicularis, you do meatotomy at the urethral meatus and remove the stone. Now, the other procedures include the ureteric reimplantation for impacted distal stones. You may have to do partial nephrectomy if the stone is really in the kidney, the parenchyma, or you can actually do total nephrectomy if you think this, for example, the stone has caused obstruction and the kidney is non-function. So in the lithotripsy, this is stone fragmentation using lithotripters, and the first clinical application with successful fragmentation of renal stones was in 1980. And these approaches, lithotripsy, they use shock waves, just like you hear ultrasound waves. So you use shock wave is percutaneous or it is endoscopic. This is a diagram just showing you a patient positioned and the machine that does extracorporeal shockwave lithotripsy delivers the shock waves to the kidney, therefore fragmenting the stone. The fragments of the stone then may come out by themselves. So don't be wondering where the fragments will go. This is a machine also showing you a patient position, and these guys are doing extracorporeal shockwave lithotripsy. Now, how do you select the surgical modalities to use for treatment of the stone within the kidney? The stone composition, we said calcium stones are hard, and so sometimes fragmenting them may be difficult. The renal anatomy should be considered, and of course, the renal function. So the staghorn stones are very special because usually they may even occupy the whole, all the calyces and the pelvis. And if you use shockwave lithotripsy, for example, the results may not be very good. And of course, complete removal with the percutaneous nephrolithotomy may give you better options. Open pyrolithotomy or anatrophic nephrolithotomy may be considered for patients with extremely dilated collecting systems or staghorn stones, which have multiple extensions in the calyces. Then the anatrophic nephrolithotomy renders a patient free of stones, approximately 65 to 90% of the times. It is associated with high complication rates, and a significant time is required for the patient to be fine and to be discharged. So indications for the open nephrolithotomy is failure of the shockwave lithotripsy or the percutaneous nephrolithotomy. Then patients who are obese, you may not be able to use the shockwave lithotripsy. Then patients with multiple medical problems may also benefit from open surgery because they are shorter and you are sure. You do open surgery and you get the stone out physically. Then stones in the collecting system with distal obstruction may also require that you do open surgery. Obstructed or stenotic calicioinfundibular may also require that you do open surgery. There are sometimes where you have extremely large stones. You should go straight for open surgery. Much as it is invasive, it will give you better results. If the stone is complex and it branches into the calyces also, you may want to do open surgery. Then, of course, patients who have renal anomalies or congenital anomalies associated with stones, you may also want to do open surgery, so that you don't only remove the stone, but you remove the stone and also sort out the congenital anomaly. So with that, we've come to the end of the presentation. I hope that you have benefited a lot from this lecture, and I will ask Pade to coordinate the session of the questions. So Pade, over to you.
Thank you so much, Dr. Lithotripsy, I do not understand them. So in case you have a question, just put up your hand and we shall deal with, I think, 3 questions and we'll let the doctor rest.
I know you also want to rest because you have had a marathon today.
Muonge, please unmute and ask your question.
Yes, thank you very much, Doctor. Doctor, I'd like to know how we can differentiate between the different compositions of the stones on clinical presentation. Like, I would like to know how we can differentiate between the different compositions of the stones.
The different types of the stone.
Presentation, because of clinical presentation.
From clinical presentation?
Yes.
So you can't differentiate the stones from the clinical presentation. You can't differentiate the types, but of course you can know the location of the stones. If the stones are in the bladder, you may know, because the patient may have irritative symptoms. The patient may have also bladder outlet obstruction. If they are in the ureter, then there is a pattern of where the pain may radiate. So you can know where the stone is from the history and the examination, but you cannot know the different types of the stones unless you do imaging. We said calcium stones are radiopaque, so if you find stones that are radiopaque, most probably they are calcium. If you find those that are radiolucent, then most probably they are uric stones. Of course, maybe in your history, you may also get some information. Like, for example, if a patient says, I've been getting gout, then you may suspect that they have uric stones. Thank you.
Thank you much. So Mulunji Jonathan, please unmute and ask your question. Those of you, because of
okay, thank you, Dr. Marvin.
You can type your
question is for the patients that have gout, let's say in Uganda, how often do you see them presenting with urethral stones?
So thank you for the question. Uric stones are generally not very common. Of course, for us, they are not very common because we also don't see so many patients with gout. But patients who have gout, it's important to know that if they present with any symptoms suggestive of a stone, they should be investigated for uric stones, and you have to keep in mind that they are radiolucent. So you may want to do a CT after missing them on the X-ray. And even if you don't see them on CT, you should still have increased index of suspicion.
Okay,
so we shall have one more question, and then I'll leave you guys to also rest.
Okay, Bwire, please unmute and ask your question.
Thank you, Dr. Marvin, for the lecture. My question is, I've seen urologists like Dr. Nasang and Dr. Watia using sodium taurocholate to dissolve renal calculi successfully. Now, in our setting, how do we tell that this renal calculi will respond to chemotherapy or this one will require surgery? Thank you.
Dr. Marvin, did you hear the question?
Sorry, I was muted. So I was saying that how you predict that a particular modality may help your patient depends on the type of stone you have. For example, if you have uric stones, and we already said that for uric stones, they require acidic urine. That means that agents that alkalinize urine are likely to help you. If you have calcium stones, which are very hard, you are very unlikely to achieve to achieve much. So it depends on the type of stone you have. Generally, calcium stones are the commonest. They are very hard, and you may not be successful using non-invasive, or I mean, if you use conservative methods, you may not actually achieve much. So that's how you select. So it's important that you actually know that the type of the stone is a particular type, then you can decide. Of course, you must also keep monitoring these patients. If you give your agents, then you must keep doing tests to see. For example, if you give drugs for alkalinization of urine, then you should keep checking for the pH of urine, whether it has increased. Thank you. So I think with that, it is okay to thank you for attending. I see we have only 36 people who have attended. Maybe people are sharing, like you usually tell me. But I'm positive that you've understood how stones form and how we treat. I encourage you that now you go and read more. You'll get details of how big the stone is for you to do the minimal invasive and the like. I would like to also encourage the new group that will be coming to urology to come on Sunday, because we have only one operating day, which is Monday. So when you appear on Monday and you don't know the cases, it becomes very difficult discussing those cases as I operate. So please come on Sunday so that we are together. You get involved in preparing the patients, you clerk them before, so that on Monday you are par. Otherwise, with that, I wish you a nice weekend. Maybe just to mention that I would like us to do the exam of urology mid this month. And when I say that, I see we only have 2 opportunities for the lectures. I wanted to suggest that just like we've used extra time, if you organize yourselves better, next week we should be able to cover priapism and erectile dysfunction, and also look at the neurogenic bladder. So you work around it per day and you let me know.
Okay, doctor, we shall see about rescheduling those lectures. And
Okay.
maybe clarification, what time should the people rotating on in this coming week come on ward on Sunday?
They should come on at around 10, 11.
Okay, doctor.
Yes.
Thank you so much.
Carl, enjoy the weekend.